Hello everyone, I am myself Dr. Rajesh Guba. I am the general medicine educator. In this session, I will be discussing a very important topic in the neurology, that is the Alzheimer's disease. So, Alzheimer's disease, it is a form of the dementia. And what exactly is the definition of dementia? Dementia, it is a progressive decline, right? It is a disorder where there is progressive decline in intellectual function. Right, it is a disorder where there is progressive decline in progressive decline in the intellectual function of the individual, and that progressive decline in intellectual function is severe enough to compromise social or occupational functioning. Okay, that progressive decline, whatever is there, that is so severe that it will compromise this will compromise the social or occupational functioning of the individual. And we have one more important terminology called mild cognitive impairment. See, mild cognitive impairment describes a decline that has not resulted in the change of level of function. So, mild cognitive impairment. What is the difference between dementia and as well as the mild cognitive impairment? In case of mild cognitive impairment, there is no change in the level of function. Right, so that is the mild cognitive impairment. So it describes a decline that has not resulted in change in the level of function. Okay, whereas in case of the dementia, there is progressive decline in the intellectual function. It is so severe enough that will compromise the social or occupational functioning of the individual. Now, these two clinical scenarios, that is the dementia and as well as delirium, how both are different. Dementia, it is distinct from delirium and psychiatric diseases. In case of delirium, what will be the manifestations? Delirium, it is an acute confusional state. Right, it is an acute confusional state that often occurs in response to an identifiable trigger. Right, so here here you have an identifiable trigger. And what is that particular trigger? Such as a drug or alcohol intoxication, right, such as drug or alcohol intoxication or the drug withdrawal. That is what is the difference between delirium and as well as dementia. Delirium, it's an acute confusional state that often occurs in response to an identifiable trigger, and that trigger is either a drug or alcohol intoxication or the withdrawal of a drug. Next, as such, if you take the Alzheimer's, what type of dementia is this? Is it subcortical dementia? Is it a cortical dementia? Is it both cortical and subcortical dementia? Brainstem disease. Let me tell you, the Alzheimer's, it is a cortical dementia. Now, let me tell you the examples of the cortical dementias. Your Alzheimer's is a cortical dementia. And apart from the Alzheimer's, we have many other disorders which are the cortical dementias. See, the mnemonic for that cortical dementias is, you remember this mnemonic, pick me at CC day. Okay, what does this P stands for? That is Pick's disease. Right, that is the Pick's disease. And this Pick's disease, it is frontotemporal dementia. Right, Pick's disease, it is frontotemporal dementia. And what about C? It is dementia due to Creutzfeldt-Jakob disease. So C stands for Creutzfeldt-Jakob disease. And another C, if you take, that is dementia due to a chronic subdural hematoma. Right, dementia due to chronic subdural hematoma. And another D is dementia of Alzheimer's. Right, so these are all your cortical dementias. Then followed by the cortical dementias, then you need to know which are all subcortical dementias, and the mnemonic for that is the dash diet. And which group of patients they acquire this dash diet? That is, in patients with the hypertension, they acquire this dash diet. Now what does this dash stands for? The mnemonic for subcortical dementias. D stands for dementia due to HIV. Right, dementia due to HIV. Then if you take this word A, that is the dementias which occurs in aged individuals, that is Parkinson's disease. Right, Parkinson's disease. And the word S stands for sclerosis. What sclerosis is this? That is multiple sclerosis. That will be another important cause for subcortical dementia. And you take the word H, stands for Huntington's disease. Right, so these are all the causes for subcortical dementias. Okay, so dementia due to HIV, then dementia in aged individuals, that is Parkinsonism. S stands for sclerosis, that is multiple sclerosis, and another H is the Huntington's disease, right? And we also have the progressive supranuclear palsy, PSP. Even this also causes the subcortical dementia. Then followed by that we have mixed dementias. Mixed dementias means the one who have both cortical and as well as the subcortical dementia, and the mnemonic is the DVD. Right, and in this particular DVD, what does this D stands for? D stands for dementia due to Fragile X associated disease. Right, dementia due to Fragile X associated disease, and the V stands for vascular dementias. And what are the examples of this vascular dementia? That includes secondary to stroke, that is post-stroke, and then we have multi-infarct dementia. Right, then we have multi-infarct dementia, that will be your vascular dementias. And the last D, that is dementia of Lewy body. That is Lewy body dementia. Right, so these three forms of dementias you need to be aware. That is cortical dementia, subcortical dementia, and then the mixed dementias, where there is involvement of, or where there is both cortical and as well as the subcortical involvement. Now, after having discussed about the classification of the dementias, you need to know what are the reversible causes for the dementias. The reversible causes for dementias, like we have certain drugs, like alcohol intoxication can cause dementia, which is reversible. Then E stands for emotional disorders. And these emotional disorders include like depression. M stands for metabolic encephalopathy or metabolic causes. And what are these metabolic causes? That includes hepatic encephalopathy, then hypothyroidism, then followed by that chronic renal failure. So these are the metabolic causes for the dementia. E stands for eye and ear dysfunction. Right, eye and ear dysfunction. N stands for nutritional disorders. Right, N stands for the nutritional disorders, and normal pressure hydrocephalus. So these are the nutritional disorders and normal pressure hydrocephalus. And T stands for tumor and then trauma. Right, so these are the reversible causes of the dementias. Right, drugs, emotional disorders like depression, metabolic causes like hepatic encephalopathy, hypothyroidism and chronic renal failure, ear and eye dysfunction, nutritional disorders and normal pressure hydrocephalus, then tumor and as well as the trauma. So these are the reversible causes for dementia. Now, we will come back to the Alzheimer's. So, the predominant site which is affected in Alzheimer's, the options are temporoparietal lobe, frontotemporal lobe, occipital lobe, the parieto-occipital lobe. Let me tell you, the anatomical site which is affected in Alzheimer's will be the temporoparietal lobe. Now, let me discuss what are the anatomical sites which are affected in the cortical dementias. In Alzheimer's, number one, it is your temporoparietal cortex predominantly. Right, temporoparietal cortex predominantly. Then followed by that, there is involvement of the frontal lobe. Then you take in case of the Pick's disease. In Pick's disease, the part of the, which particular lobe is affected? That is frontotemporal cortex. Right, that will be the frontotemporal cortex. That will be the Pick's disease. Now, followed by that, you need to know what are the parts of the hippocampus, because the hippocampus is a seat of memory. Hippocampus formation includes all except dentate gyrus, subiculum complex, amygdaloid nucleus, entorhinal cortex. Let me tell you, in case of hippocampus, you don't, first let me tell you what are the structures which will form the hippocampus. So the hippocampal formation is a compound structure in the medial temporal lobe of the brain. Right, it is a compound structure which is present at which is present at medial temporal lobe of the brain. And what are the constituents of this, the hippocampal formation? That includes the dentate gyrus, right? Number 2, the hippocampus proper, then followed by that subiculum, right? So it's a compound structure which is present on the medial temporal lobe of the brain, containing dentate gyrus, hippocampus proper and the subiculum, right? And others included structures are, I'll tell you. So now you go back to this question now. Hippocampal formation includes all except the amygdaloid nucleus. That means what are the other structures which are included in this hippocampal formation? See, apart from these three, that is dentate gyrus, hippocampus proper and as well as the subiculum, the other structures which are present is the entorhinal cortex, then you have presubiculum and parasubiculum. Right, pre and as well as the parasubiculum. Now, what about the amygdaloid nucleus? Amygdala, it is the very important role of amygdala is the processing of the memory. Right, it is involved in the processing of the memory. And this amygdala, not only it is involved in processing of memory, it also has an important role in decision making, then followed by that, it also plays an important role in emotional reactions, right? Emotional reactions. This is what is the role of amygdaloid nucleus. And this amygdaloid nucleus, it is considered as the part of the limbic system. Right, it is considered as the part of the limbic system. That is about your amygdaloid nucleus. Whereas the hippocampus formation, it includes the dentate gyrus, subiculum, entorhinal complex, then you also have parasubiculum, presubiculum, then hippocampus proper. These are all the parts of the hippocampal formation. Next, followed by that, what is the true statement about the Alzheimer's disease? Most cases are sporadic, majority of them are autosomal recessive trait, majority are autosomal dominant trait, 5% cases are sporadic. So the true statement about the Alzheimer's is that most of these cases of the Alzheimer's, they are sporadic, right? So if you take this Alzheimer's, it is a progressive degenerative disease of the brain accounting for majority of dementia, right? It is a progressive degenerative disease of the brain, right, which accounts for majority of dementia. Right, which accounts for majority of dementia. And most of the cases of Alzheimer's, they are sporadic. right? Mostly they are sporadic. And 5% of cases are inherited, and they are being inherited as an autosomal dominant trait, right? They are inherited as an autosomal dominant trait, okay? And in case of the Alzheimer's, there are certain protein abnormalities. Following protein abnormality is not seen in Alzheimer's disease: amyloid precursor protein presenilin 1, 2, 3. Now, you need to know the mutation of the genes is responsible for abnormality in which all proteins. Please remember this mnemonic APP. So, APP, the word A stands for amyloid precursor protein. Right, this amyloid precursor protein, it is present on chromosome 21, and another P is presenilin, right? Presenilin 1. This presenilin 1, it is present on chromosome 14, and then we have presenilin 2. This presenilin 2, this is present on chromosome 1. So, these three important abnormalities are the one which are responsible for the development of the Alzheimer's. So, following protein abnormality is not seen in Alzheimer's, that is, the presenilin 3 abnormality is not seen. Then, you need to understand that for the development of Alzheimer's disease, there are certain risk factors that should be there. Now, the question is, what is the most common risk factor for Alzheimer's disease? Positive family history, female gender, low educational status, adults with the trisomy 21. Let me tell you, we have many risk factors, I'll tell you all. But among all these, the most common risk factor for Alzheimer's is the positive family history. Now, you take the other risk factors, right? The other risk factors in case of the Alzheimer's. So, we have certain factors which are associated with increased risk of certain factors associated with increased risk of Alzheimer's. And these factors which are associated with increased risk of Alzheimer's disease include: number 1, increasing age of the individual. Females, they are at more risk of development of Alzheimer's. Then, low educational attainment. Family history of dementia. Then, numerous environmental factors. And these environmental factors, it includes the viruses and prions, viruses and prions. And apart from that, we have several genetic factors as well. We have several genetic factors as well. That is amyloid precursor protein on chromosome 21. And another important genetic factor is adults with trisomy 21, that is Down syndrome. Adults with trisomy 21, that is Down syndrome. So, these are the factors which will increase the risk of the development of Alzheimer's disease. And what are the factors which are associated with decreased risk of Alzheimer's? So you should know what are the factors which will decrease the risk of the Alzheimer's. These factors include post-menopausal estrogen use, right, post-menopausal estrogen use, and then use of the NSAIDs, that is NSAIDs use. So these are the factors, they decrease the risk of the Alzheimer's, NSAIDs and postmenopausal estrogen use. Now, remember the most important risk factor for Alzheimer's are old age and the positive family history. These two are the important risk factors, and you need to know what are the drugs that decrease the risk of the Alzheimer's. NSAIDs, ACE inhibitors, beta blockers, and then modafinil. Please remember the drugs that decrease the risk of Alzheimer's is the NSAIDs, right? That is non-steroidal anti-inflammatory drugs. They decrease the risk of the Alzheimer's disease, right? Whereas ACE inhibitors, beta blockers, modafinil, they have no role in the risk of the Alzheimer's. Now, followed by that, you take the pathological changes, right? You take the pathological changes in Alzheimer's. What exactly will happen? So, if you take macroscopic appearance, there is widespread cerebral atrophy. Right, there is widespread cerebral atrophy, and this widespread cerebral atrophy particularly involving the cortex and hippocampus. Right, so these are the pathological changes macroscopically that you will have in the Alzheimer's disease. Then if you take the microscopic appearance, so you see this is the normal brain and this is a brain of a patient with Alzheimer's where you have the atrophy. Next, now let me discuss the histological changes in Alzheimer's. Which of the following are the intracellular accumulations in Alzheimer's disease? Beta amyloid plaques, neuritic plaques, senile plaques, neurofibrillary tangles. Now let me discuss that in patients with the Alzheimer's, you have the presence of the neurofibrillary tangles as the intracellular accumulations, and they also assess the severity of the disease as well. So, if you take the histopathological accumulation in Alzheimer's, histopathological accumulations, we have number one, the beta amyloid, and then we have hyperphosphorylated tau protein. Right, hyperphosphorylated tau protein. So, if you take this beta amyloid plaque, this beta amyloid plaque, it is accumulated in the form of senile or neuritic plaques, right? It is accumulated in the form of senile or neuritic plaques, or there will be amyloid angiopathy. Right, there will be amyloid angiopathy, whereas hyperphosphorylated tau proteins, right, hyperphosphorylated tau proteins, they are being accumulated as neurofibrillary tangles. Right, they have been accumulated as the neurofibrillary tangles. So that will be the hyperphosphorylated tau proteins. Now, where these are being accumulated, let me discuss which are extracellular, which are intracellular. See, you take this beta amyloid plaques. These beta amyloid plaques, these are the extracellular. Whereas the hyperphosphorylated tau proteins, that is neurofibrillary tangles, these are intracellular. Now, let me discuss in detail about these. You take the beta amyloid plaques, right? So, beta amyloid plaques or the neuritic plaques are formed by extracellular accumulation of beta amyloid deposit within the neutrophil. So, you have the beta amyloid deposit within the neutrophil, right? And that will be responsible for the formation of beta amyloid neuritic plaques. And this neuritic or senile beta amyloid plaques, these are an early histopathological sign. Right? These are an early histopathological sign of Alzheimer's disease. And you know, this can occur rarely in healthy subject also. And the amyloid beta protein accumulated in single neuritic plaque is toxic to the surrounding structures. Okay, so this beta amyloid plaque, it is toxic to the surrounding structures and as well as the adjacent neurons. And let me tell you, this beta amyloid plaques, right, it will give the amyloid burden, but it does not directly correlate with severity of the disease. Okay, so these beta amyloid plaques, they do not correlate with severity of the disease. That is about the beta amyloid plaques, which are extracellular accumulations within the neutrophils, and because of their accumulation that give toxicity to the surrounding structures and as well as the adjacent neurons, and these do not directly correlate with the severity of the disease, or it will not tell you about even the duration of the disease as well. Then followed by that you take the neurofibrillary tangles. Neurofibrillary tangles, they are intracellular accumulations, right? And how are they formed? They are formed by intracellular accumulation of the hyperphosphorylated microtubule binding protein, that is tau protein. Okay, it is due to accumulation of right, it is due to accumulation of the hyperphosphorylated microtubule binding protein, that is tau protein. Right, it is due to accumulation of hyperphosphorylated microtubule binding protein called tau protein. And these neurofibrillary tangles, right, these neurofibrillary tangles, they occur in many neurodegenerative disease, right? They occur in many neurodegenerative diseases, and that particular group of diseases, they are called tauopathies. Okay, they occur in many neurodegenerative diseases, and those particular diseases where you have the accumulation of the neurofibrillary tangles, these particular diseases we call it as, right, we call them as the tauopathies. And what are the examples of the tauopathies? The examples of the tauopathies include frontotemporal dementia, then Pick's disease, and the occurrence of, the co-occurrence of the beta amyloid plaques with neurofibrillary tangles together suggest the Alzheimer's disease. So, in Alzheimer's disease, along with the neurofibrillary tangles, you have the presence of the beta amyloid plaques. Right, you have the presence of the beta amyloid plaques, and these two together constitutes what is called the Alzheimer's. And these neurofibrillary tangles, these neurofibrillary tangles, they are toxic to the neurons, and neurons with neurofibrillary tangles eventually die and degenerate, leaving a residual ghost tangle. Okay, so these neurofibrillary tangle, they are toxic to the neurons, right? And these neurons with the neurofibrillary tangles, these neurons with neurofibrillary tangles, they eventually die, they eventually die and degenerate, leaving a residual leaving a residual ghost tangle. Okay, now that is what is the importance of neurofibrillary tangles. And these neurofibrillary tangles, once the neurons die and they get degenerated, the intracellular accumulations, they become extracellular, they become extracellular, otherwise they are intracellular. But once the neurons die and get degenerated, they get accumulated in the extracellular space. And these neurofibrillary tangles, let me tell you, they also decide the severity of the disease. Okay, so you see this point. Clinico-pathological studies have shown that dementia correlates more strongly with neurofibrillary tangles than with beta amyloid plaques. More is the quantity of neurofibrillary tangles, more severe is this particular disease of the Alzheimer's. Okay, next, then followed by that, so what did I tell you? Neurofibrillary tangles are intracellular accumulations that may appear extracellularly after degeneration of the neuron or after the neuronal death. Right, so you see this neurofibrillary tangles, where are they present? Intracellularly. Beta amyloid plaques, where are they present? Outside the cell. Now followed by that, you see the next point. Earliest histological change in Alzheimer's disease. Neurofibrillary tangles, hyperphosphorylated tau protein, senile beta amyloid plaque, Lewy body accumulation. Just now we have discussed, it is the senile beta amyloid plaques which are the extracellular accumulations that will be the earliest histological change in Alzheimer's disease. And which of the following structure is not affected in Alzheimer's disease? Entorhinal cortex, limbic system, temporal cortex, and then lateral geniculate body. Let me tell you, in case of Alzheimer's disease, there is no involvement of the lateral geniculate body. So, if you see the structures which are affected in Alzheimer's, that is topographic distribution of the neurofibrillary tangles. So, in Alzheimer's, the neurofibrillary tangles, they are deposited within the entorhinal cortex, right, which is a part of, the hippocampus, and they also get accumulated in the limbic and temporal cortical areas. Right, limbic and temporal cortical areas, these are next most affected. Most vulnerable are the entorhinal cortex, which is a part of the hippocampus, and amygdala connection, right? So hippocampus amygdala interconnections, they are most vulnerable in case of the Alzheimer's. And the next important is the association areas of the neocortex. Right, the association areas of the neocortex. So these are the structures which are affected in the Alzheimer's disease. And let me tell you, the lateral geniculate body is usually not affected in patients with the Alzheimer's disease. Right? So you see a question. 80-year-old female presented with progressive loss of memory, difficulty in recalling the names, difficulty in speech, inability to perform the desired task. Which of the following pathological feature is likely to be found along with the neurofibrillary tangles? Beta amyloid plaque, ceramidase, Lewy body, Pick's disease. So what is this clinical scenario suggestive of? It is suggestive of Alzheimer's. So in Alzheimer's, along with the neurofibrillary tangles, you have the presence of the beta amyloid plaques. Now, followed by the histopathological changes, then you need to know what are the biochemical abnormalities seen in Alzheimer's disease. So, all of the following biochemical abnormalities are seen in Alzheimer's disease except decreased acetylcholine, decreased noradrenaline, decreased serotonin, decreased dopamine. Let me tell you, decreased dopamine, that is not the feature of the Alzheimer's disease. Now, let me tell you what are the biochemical abnormalities in Alzheimer's disease. So, we have primary biochemical abnormality, that is decreased levels of the neurotransmitter, and this primary biochemical abnormality where there is decreased levels of neurotransmitter include acetylcholine. Right, there is decreased level of the acetylcholine. Right. And you know, for the synthesis of this acetylcholine, you require an enzyme called choline acetyltransferase. Right? There will be defect or biochemical abnormality of the enzyme which is required for the synthesis of the acetylcholine. And it has been suggested that deficiency of acetylcholine is related to loss of memory in patients with the Alzheimer's. Right? It is mainly because of decrease in acetylcholine that is responsible for the development of dementia in these individuals. Now, apart from these, there are few more biochemical markers or biochemical neurotransmitters that are being decreased. Right? What are the other neurotransmitters which are being decreased in the Alzheimer's? That includes, there will be decrease in norepinephrine or noradrenaline, decrease in serotonin, right, and there is also decrease in somatostatin. Right, somatostatin. So, levels of above 3 neurotransmitters are reduced in brain of some patients with the Alzheimer's disease. But this acetylcholine is definitely released. But whereas others, they are being released in some patients with the Alzheimer's disease. Right? And it has been suggested that the deficiencies of these substances are related to sensory disturbances and aggressive behavior in patients with Alzheimer's. So, this is related to impairment of the memory in patients with the Alzheimer's, whereas these biochemical abnormalities, they are related to impairment of sensory function and development of the aggressive behavior. Right, development of aggressive behavior. Whereas if you take the dopamine, let me tell you, decreased dopamine, that is not the feature of the Alzheimer's disease at all. Right? So the biochemical abnormality is there is deficit of acetylcholine from damage to an ascending forebrain projection. Now, your Alzheimer's, it is a neurodegenerative disorder. Now, if you take the classification of the neurodegenerative disorders, they have been classified based on the inclusion body within the neuron. So, we have what is called tauopathies, right, where you have accumulation of tau protein. And second, we have the accumulation of alpha-synuclein protein, that is called synucleinopathies. Then we have amyloid-beta protein accumulation, which is called amyloidopathies, right, which is also called amyloidopathies. Now let me discuss what are the examples of, right, what are the examples of the tauopathies. So examples of the tauopathies, if you see, the mnemonic is TAP, right, the mnemonic is TAP. So what does this TAP stands for? P is your Pick's disease, right? A is your Alzheimer's, right? A is your Alzheimer's. And another, if you take the T, where you have tufted astrocytes, where is that you have tufted astrocytes? You will have that in progressive supranuclear palsy. So even your progressive supranuclear palsy, it is also a tauopathy. Then you take the synucleinopathies. Synucleinopathies, the examples are multi-system atrophy, right, which is nothing but the Shy-Drager syndrome. It is alpha-synuclein protein accumulation. Then amyloid-beta protein accumulation, that is amyloidopathies, include number 1 Alzheimer's, right, and then cerebral amyloid angiopathy. Right, so that is about the amyloid beta protein accumulation. So we have tauopathies, then synucleinopathies, and then the amyloidopathies. Right, now after having discussed about the various neurodegenerative disorders, let me tell you, depending upon the protein aggregations in major dementias and related cognitive disorders. You take the Alzheimer's. The protein which is accumulated is amyloid beta and as well as tau protein. Whereas you take the tauopathies, that is the frontotemporal dementia, progressive supranuclear palsy and corticobasal degeneration, it is a tau protein which is accumulated. Whereas in Parkinson's disease and as well as multisystem atrophy, it is synucleinopathies, that is alpha-synuclein which is accumulated. Huntington's disease, it is the Huntington protein which is accumulated, and in prion disease, it is the prion protein. Spinocerebellar ataxia, it is ataxin protein which is being accumulated, right? Now, after having discussed about the basic introductory points, pathogenesis in Alzheimer's, let me now come on to the discussion of the clinical features in patients with the Alzheimer's. So, if you see the clinical features in patients with the Alzheimer's disease, first and foremost, very important is the short-term memory loss. So, short-term memory loss involving the repeating of questions or stories and a diminished ability to recall the details of recent conversations or the events. So, these individuals, they have diminished ability to recall the recent conversation and as well as the events, right? So that will be the form of your short-term memory loss, okay? And why does this short-term memory loss occurs in patients with the Alzheimer's? That is mainly because of the pathological changes in hippocampus, okay? That will result in what is called the short-term memory loss. And the next important abnormality in Alzheimer's will be the word finding difficulty. See, this particular word finding difficulty is like recalling the names of people, recalling the names of places, recalling the names of objects, these get affected, right? So they have difficulty in recalling the names of the people, places, and as well as the objects. Okay, so that is what is your word finding difficulty. And this problem of word finding difficulty is thought to arise from pathology at the temporoparietal junction of the left hemisphere. So here the site of pathology is at right, it is at temporoparietal junction of left hemisphere. So that will be the word finding difficulty, and followed by that these individuals will also have the visuospatial dysfunction. This visuospatial dysfunction may result in the poor navigation and getting lost in familiar places, right? So they have poor navigational abilities and getting lost right, getting lost in familiar places. So this will be your visuospatial dysfunction. And there is also impaired recognition of previously familiar faces. They have impaired recognition of previously familiar buildings, right? And where exactly is the site of pathology for the development of visuospatial dysfunction is in the right parietal lobe. Okay, so right parietal lobe is one of the brain areas implicated in the development of the visuospatial dysfunction. Then followed by that, executive dysfunction. See, this executive dysfunction, it may manifest by easy distractibility, right? Easy distractibility, then mental inflexibility, then the individual has slowed processing speed, then followed by that there is poor planning and organization. Right, poor planning and organization. So this is what is your executive dysfunction. And where exactly will be the site of pathology for the development of this abnormality in executive dysfunction? The site of pathology will be in the frontal lobes or at the subcortical areas like the basal ganglia. Right, subcortical areas like basal ganglia. Okay, so this is about your executive dysfunction. Then followed by that, the individual will also have the apathy or indifference. Now what is this apathy or indifference? It is the clinical condition where the individual has separate from depression, there is an indifference. So in these individuals, depression is one of the manifestation, right? And why there is depression? That is because of the similar structure which is affected in executive dysfunction, that is due to the involvement of the frontal lobe, the individual will have apathy or indifference, right? Apathy or indifference separate from depression is common and may have similar anatomy as the executive dysfunction. So these are the manifestations. So until now, like what all we have discussed, number one, short-term memory loss. That is mainly because of the involvement of the hippocampus. Then word finding difficulty. That is due to the pathology at the temporoparietal junction of the left hemisphere. Then we have the visuospatial dysfunction. That is due to the involvement of the right parietal lobe. Then the next important manifestation is executive dysfunction. That is due to the involvement of the frontal lobe. And apathy or difference is also due to the involvement of the frontal lobe. Then followed by that, how is that you will do the neuropsychological assessment of Alzheimer's? So brief quantification of cognitive impairment is indicated in a patient complaining of the cognitive symptoms. So how is that you will do the quantification of the cognitive impairment? We have various scales. We have various scores. That includes number one, Falstein mini mental state examination. Right, Falstein mini mental state. Examination, that is MMSE. And second, Montreal cognitive assessment. Right, Montreal cognitive assessment scoring system. Then we have mini cog. Right, then we have mini cog. Okay, so these are some of the scales and scoring systems which are used to quantify the cognitive impairment. Then followed by that, the imaging studies in Alzheimer's. So brain imaging with MRI or CT without contrast is indicated in any patients with a new progressive cognitive complaint. Okay, without contrast. Right, without contrast is indicated in any patients with a new progressive cognitive complaint. And what is the goal of doing this CT or MRI is to exclude the occult cerebrovascular disease. Right, to exclude the occult cerebrovascular accident or cerebrovascular disease. What do you mean by the word occult? That is hidden. Cerebrovascular disease can be excluded by your CT or MRI, and it will also exclude if there is any presence of the tumor, and it will also exclude if there is any structural abnormality. Right, if there is any presence of structural abnormality. That is the purpose of doing the MRI or CT. The next important is the PET scan or the positron emission tomography imaging. Now, this particular PET imaging with a radio-labeled ligand with a radio-labeled ligand, this is done for the detection of the beta amyloid. Right, this is done for the detection of the beta amyloid. And this beta amyloid, it is one of the pathological protein in Alzheimer's or Alzheimer's disease. Okay, and it is highly sensitive to amyloid pathology. Which one? The presence of the beta amyloid. It is highly sensitive to your Alzheimer's disease. Right, that is the purpose of doing your PET scan, wherein you will be able to detect where all is the distribution of the beta amyloid, which is highly sensitive for Alzheimer's disease. Then, and if you take the other investigations in these individuals, You have to check for serum vitamin B12 level, because vitamin B12 deficiency can cause the Alzheimer's disease. Then you need to do the thyroid functions, and the purpose of doing the thyroid function test, right, the purpose of doing the thyroid function test is to rule out the hypothyroidism, because hypothyroidism can cause the dementia. And you need to do a serum rapid plasma reagent test, right, that is to rule out the syphilis. And even the testing of the HIV has to be done, that is to rule out the HIV associated dementia. So that is about the investigations in patients with the Alzheimer's. Then how is that you will treat the patients with the Alzheimer's? Which of the following are not acetylcholinesterase inhibitor? See, basically, the acetylcholine levels are reduced in patients with Alzheimer's. So your goal is to increase the acetylcholine levels. And in order to increase the acetylcholine levels, you need to give acetylcholinesterase inhibitors. So you see here, acetylcholine, in the presence of acetylcholinesterase, it is converted into acetyl plus choline, right? And you need to give this acetylcholinesterase inhibitors. If you inhibit this enzyme, then acetylcholine levels, they are elevated, right? Then the acetylcholine levels are elevated. And what are the drugs that you have to give to increase the acetylcholine levels? So which of the following is not the acetylcholinesterase inhibitor? The options are donepezil, galantamine, rivastigmine, and then memantine. So the answer to this question is the memantine, right? Memantine, it is not the acetylcholinesterase inhibitor. Now let me discuss the treatment in Alzheimer's. So in treatment, we have non-pharmacological approaches, and then we have the pharmacological approaches. So you take the non-pharmacological approaches. Aerobic exercise for 45 minutes, right? Aerobic exercise for 45 minutes most days of the week will help in improving the memory in patients with the Alzheimer's. Then frequent mental stimulation. Frequent mental stimulation may reduce the rate of the functional decline, right? Will reduce the rate of the functional decline, and decrease the demented patients' caregiving needs as well. So caregiving in these patients will also be decreased whenever you do a frequent mental stimulation. And these interventions may reduce the risk of dementia in normal individuals also. Then you need to supplement the vitamin E. Vitamin E, 1000 international units twice daily. When you give this, it appears to reduce the rate of functional decline in patients with Alzheimer's disease. So this will reduce functional decline in patients with the Alzheimer's. But let me tell you, this vitamin E does not affect the cognition or prevent the development of Alzheimer's in patients with mild cognitive impairment, right? It does not affect the cognition, or it does not prevent the development of Alzheimer's disease in patients with mild cognitive impairment. So that is about the vitamin E supplementation. Then followed by that, if you take the drugs which will increase the acetylcholine, so we have 3 acetylcholine esterase inhibitors. So what are the examples of 3 acetylcholine esterase inhibitors? That includes, number 1, donepezil. Third, we have galantamine. Second, galantamine. Third, right? We have rivastigmine. These three are the acetylcholinesterase inhibitors, and these are used in the management of mild to moderate Alzheimer's disease. Right, these are given in the treatment of mild to moderate Alzheimer's disease. Whereas if you take this particular drug, that is memantine, memantine is also the drug which is given in the treatment of Alzheimer's, but it is not an acetylcholinesterase inhibitor. It is NMDA receptor antagonist. Right, it is an NMDA receptor antagonist, and this memantine, right, this memantine, it is given in the treatment of moderate to severe form of the Alzheimer's, right? That is about the memantine. So if you take these cholinesterase inhibitors, these cholinesterase inhibitors, they are considered as the first line treatment for the Alzheimer's disease, and it is also the first line treatment, AD stands for Alzheimer's disease, and it is also the first line treatment for dementia with Lewy body. Right, dementia with Lewy body. And this cholinesterase inhibitors, they provide modest symptomatic improvement or symptomatic treatment for cognitive dysfunction. Symptomatic treatment for symptomatic treatment for the cognitive dysfunction. And these cholinesterase inhibitors may prolong the capacity for independence but do not prevent the disease progression. What they will do? They will only prolong the capacity for independence, but they do not prevent the disease progression. Right? They do not prevent the disease progression. Okay, so that is about the cholinesterase inhibitors. And we have a monoclonal antibody or a new molecule, that is aducanumab. This aducanumab, it is an antibody, right? It is an antibody which is directed against aggregated beta amyloid. Right, which is directed against aggregated beta amyloid, and this has showed promise in phase 2 trial, and phase 3 trials are going on about this aducanumab, right? So these are the treatment options for the Alzheimer's. Non-pharmacological therapy in the form of aerobic exercises, then the brain stimulating exercises, then vitamin supplements in the form of vitamin E, then followed by that the acetylcholinesterase inhibitors, NMDA receptor antagonists. So if you see this question, all of the following are tauopathies except the Alzheimer's disease, the Pick's disease, frontotemporal dementia, vascular dementia. Let me tell you, your vascular dementia is not a tauopathy. The remaining three, they are the tauopathies where there is accumulation of the tau proteins. Then all of the following causes subcortical dementia except Alzheimer's, Parkinson's, HIV encephalopathy, progressive supranuclear palsy. Let me tell you, these three, they are subcortical dementias, whereas Alzheimer's, it is a cortical dementia. Right, Alzheimer's, it is a cortical dementia. Okay, next, which of the following is predominantly involved in Alzheimer's dementia? Frontal cortex, temporoparietal cortex, frontoparietal cortex, frontotemporal cortex. So the same question we have discussed already, it is the temporoparietal cortex that is being predominantly affected in patients with the Alzheimer's. Then, all of the following are known predisposing factors for Alzheimer's except Down syndrome, low education level, smoking, female gender. Let me tell you, smoking, it is not a predisposing factor for the development of Alzheimer's, whereas the trisomy 21, that is your Downs, low educational status and female gender, they are the predisposing factors for the development of Alzheimer's. And a chromosomal anomaly associated with Alzheimer's dementia is trisomy 18, Patau syndrome, trisomy 21, Turner syndrome. Let me tell you, it is your trisomy 21, which is nothing but your Down syndrome. Next, all of the following neurotransmitter deficiencies are observed in Alzheimer's except acetylcholine, serotonin, noradrenaline, then dopamine, right? So we have already discussed the same question. These three neurotransmitters, they are decreased, but dopamine is not affected in patients with the Alzheimer's disease, right? Next, which of the following is the most important neurotransmitter deficient in the cortex of patients with Alzheimer's disease? Acetylcholine, serotonin, dopamine, noradrenaline. Remember, it is acetylcholine which is most important neurotransmitter that is deficient in the cortex. Then, Alzheimer's disease is associated with delirium, delusion, dementia, depression. Alzheimer's disease, it is associated with the development of dementia, right? It is associated with dementia. Next, all are seen in Alzheimer's disease except aphasia, acalculia, apraxia, agnosia. Let me tell you, in patients with Alzheimer's, they have aphasia, they have apraxia, they have agnosia, right? But acalculia is not the feature of the Alzheimer's. So please remember the 4 A's of dementia: amnesia, apraxia, aphasia, and as well as the agnosia. These are the 4 that you see in case of the Alzheimer's, but not the acalculia, right? Then what is this apraxia? Apraxia is inability to carry out the motor activities despite intact motor function. What is agnosia? Failure to recognize or identify the objects despite intact sensory function, that is agnosia. And the other features of Alzheimer's disease, if you see, dementia in Alzheimer's with early onset. Usually the age group is around 65 years. These individuals, in addition to the memory impairment, definitely memory impairment will be there. Apart from memory impairment, they have aphasia, loss of speech, agraphia, unable to write, alexia, indicating the presence of temporal parietal frontal lobe involvement. Acalculia is very rare or almost absent, but apraxia will be there, right? Apraxia will be there, okay? Aphasia, apraxia, agnosia, and then amnesia. These 4 A's you need to remember regarding the Alzheimer's disease. Next, so you see the next question: which of the following statements about the pathology in Alzheimer's disease is not true? Neuritic plaques are formed of amyloid protein. Neurofibrillary tangles are made up of the tau protein. Neurofibrillary tangles appear extracellularly before intracellular appearance. Number of neurofibrillary tangles correlate with the dementia. Which is the not true? Neurofibrillary tangles appear extracellularly before intracellular appearance is a wrong statement. So initially they are intracellular. Once the neuronal degeneration or neuronal death occurs, then they are spilled into the extracellular compartment. So they are intracellular, then followed by that extracellular. And neuritic plaques are formed of amyloid protein is a true statement. Neurofibrillary tangles are made up of tau protein is a true statement. Number of neurofibrillary tangles correlate with the dementia is also a true statement. Then, which of the following areas of the brain is most resistant to the neurofibrillary tangles in Alzheimer's disease? Entorhinal cortex, hippocampus or temporal lobe, lateral geniculate body, visuals association area. Let me tell you, the one which is most resistant to the neurofibrillary tangles in Alzheimer's will be lateral geniculate body, right? That is not usually affected in Alzheimer's. Next, earliest areas of brain with neurofibrillary tangles in Alzheimer's disease. Transentorhinal along with the entorhinal cortex, hippocampus or temporal lobe, limbic structures, visual association areas. So earliest areas of the brain with neurofibrillary tangles, that will be entorhinal, transentorhinal along with the entorhinal cortex. That will be the earliest area of the brain which is affected in patients with the Alzheimer's. Next. The following is not a feature of the Alzheimer's disease: neurofibrillary tangles, senile plaques, amyloid angiopathy, Lewy body. Let me tell you, Lewy body is not a feature of the Alzheimer's, right? You have separately the Lewy body dementia. So if you take the Alzheimer's, which is cortical dementia, the clinical features are prominent memory impairment, language deficit or aphasia, apraxia, agnosia, and visuospatial deficit. Pathology is the neurofibrillary tangles, right, made up of abnormal tau protein, that is why it is called tauopathy, and neuritic plaques, that is amyloid-β, present extracellularly. Okay, so these are some of the very important questions related to the topic of the Alzheimer's. And with this, I'll wind up this session of a very important topic on dementia, that is Alzheimer's disease. Thank you very much.